So thank you, Serge, and the members of the organizing committee for inviting me to this wonderful symposium. Okay, so the objectives of my talk are who are the candidates for stem cell transplantation in 2015, and one of the point which we are struggling with, what is the right time to transplant patients with myelofibrosis, especially the patients who are also the candidates for JAK inhibitor therapy, and how to integrate JAK inhibitors in the transplant protocols. So who are the candidates for transplantation for myelofibrosis in 2015? So obviously this has to be a patient in the transplant age group, patient usually less than 70-year-old, reasonable performance status, and absence of any prohibitive comorbidities. Here the upper age of transplantation is somewhat center dependent and where you are practicing. It could be less than 65 years in some countries. Some countries have no upper age limit. In Canada, we usually have transplant candidates who are 70 years or lower. I understand from my US colleagues that in US there's a major issue with Medicare that you can get transplant if you're 64-year-old, but you have difficulty in getting transplant if you're 66-year-old. And then subsequently, you obviously need to have a disease-related feature which puts you into high-risk category. And usually these are patients who are intermediate 2 or high-risk disease. And then some selected patients with intermediate 1 risk disease. And this area is somewhat controversial, and people have their own sort of, views on these issues. And usually patients who are in the intermediate 1 risk category who are considered for transplant are the patients who have high-risk cytogenetics, patients who are severely cytopenic with whom other non-transplant treatments have failed, such as patients who are transfusion dependent, patients who are severely thrombocytopenic, and more evolving field is patients who have high-risk mutational profile. And this is an evolving area where our understanding is continuously, rapidly sort of increasing. Now, this slide has been shown before. So what evidence we have that transplant benefits patients with myelofibrosis. And this is a study which is a retrospective study done by collaboration of German Center and Seattle. And here what they have done is they have divided the transplant treated patient with patients who were treated with non-transplant therapies, and they have divided according to the DIPSS risk score. So as you will see that the patients who have patients who are low risk, they're the transplant. That group of patients, transplant arm is not doing that well compared to patients who are mainly treated with supportive therapy. Whereas patients in the intermediate 2 and the high-risk category, there appears to be a statistically significant beneficial effect in the patients treated with the transplant arm. It's also important to note that patients in the intermediate 2 and the high-risk category, the benefit of transplant starts becoming apparent roughly about 5 years after intermediate 2 and 3 years after high-risk category. So till 3 or 5 years, those curves are going hand in hand. And in the patients with intermediate 1 risk category, there is no significant difference. However, if you look at the curve, transplant-treated patients tend to do sort of worse in the beginning because of the high transplant-related mortality. So this is a group where you have to make an individualized decision whom to do for transplant. So there are certain caveats for this study. This is a retrospective study. The study is done under the age of 65 years. And this study has been done in the pre-JAK inhibitor era. And we have seen that in the last 7 years, there has been a significant change in the treatments. Treatments have totally changed how we treat these patients. So this data is somewhat historical. So how do I select patients in my practice, between JAK inhibitor therapy and transplant. So it's a very individualized decision whether to go ahead with transplant or not. We do a careful assessment of patient disease and transplant-related factor, and then try to sort of, see whether patient would benefit from treating with JAK inhibitor therapy or patient upfront JAK inhibitor therapy versus upfront transplant. And obviously in these factors, the age, performance status, and comorbidities come into play a major role. So obviously advanced age, poor performance status, prohibitive comorbidities will will have a push towards choosing JAK inhibitor therapy in those patients. In addition to comorbidities, one has to be also careful about myelofibrosis-related comorbidities. And many patients have portal hypertension or pulmonary hypertension. Again, patients who have severe portal hypertension, there is a high risk of liver complications related to transplant in these patients. And that can, again, bias your decision to treat those patients more with JAK inhibitor therapy rather than transplant. On the other hand, if there is a high risk of leukemic transformation, which is usually predicted by severe thrombocytopenia, presence of high-risk cytogenetics, and more recently, high-risk mutational profiles, such as patients who have ASLX1 mutation or patients who have 3 or more mutations, then those patients could be potential candidates considered preferably to be treated with the transplant. Another factor which goes into our decision-making is what type of donor you have. And that's, again, a major factor. So why I'm saying so? So some people will say donor is a donor, so why do you need to differentiate? And these are the data which has been published from the CIBMTR registry, which shows that if you have a HLA sibling donor, your outcome is at 5 years is approximately 60%. And this drops to around 50% if there's a well-matched unrelated donor. However, it significantly drops to about 30% if the donor is 9 out of 10 or partially matched. So in my practice, this plays a significant part, whom I select for transplant. In our center, we do not differentiate between matched sibling donor and if it's a 10 out of 10 well-matched unrelated donor, we treat them similar. But if it's a 9 out of 10, then my preference is usually to treat those patients with JAK inhibitor therapy first. And if they are not doing very well on JAK inhibitor therapy or start developing complications on JAK inhibitor therapy, such as heavy transfusion dependency or increasing blasts in the peripheral blood, then I consider them using a partially matched or mismatched unrelated donor. So, and this is the timing when you should do transplant is become very, very tricky and very difficult. So I give you this clinical scenario that you have a patient who's about 62-year-old. You start that patient, and there is a clear indication of JAK inhibitor therapy. Patient, let's say, have intermediate 2-risk disease and has heavy burden of the disease. Start that patient on JAK inhibitor therapy. And 2 months later, patient is feeling so well, and then you they've seen a transplant physician, and patient comes to you and say that, why do I have to put myself through 30% risk of treatment-related mortality? So it's very, very difficult decision whether to put that patient through transplant at that time or you delay the transplant at that time. So I usually tell my patient that you can have transplant early on, where you go for transplant where you have significant clinical improvement on the JAK inhibitor therapy, or you have achieved a stable disease status on transplant on JAK inhibitor therapy, or you can delay the transplant as long as patient is benefiting from the JAK inhibitor therapy, and consider transplant if you start developing problems on the JAK inhibitor therapy. As both Rubin and Serge presented their cases, and they show that JAK inhibitor therapy does not work forever, and by 2 or 3 years, about 50% of the patients who are treated with ruxolitinib will come off ruxolitinib either due to intolerance or loss of response. So Other thing which can happen is patient can start developing transfusion dependence, or they can start having increased blast count in the peripheral blood. So that could be another timing that you could sort of delay the transplant as long as patient is benefiting from the JAK inhibitor therapy. And the third model could be, you could wait until patient sort of, clearly have major issues such as patient transforms into acute myeloid leukemia. And perhaps this scenario you want to avoid for the reasons which I've already highlighted by John's talk, that the outcome of patient with leukemic transformation is very, very poor, and you want to avoid that scenario in this setting. So what are the data? So how do the patient between model 1 and model 2 work? Again, we don't have any prospective data in this area. So this is the data one of our fellow, Dr. Mohammed Shanwaz. We did a retrospective study, and here the data have been collected from 16 centers in Canada, United States, and United Kingdom. And then we divided the outcome of the patient depending upon what was their response to JAK inhibitor therapy at the time of transplant. Now, in this model, the patient group A, mean that the patient who were having a clinical improvement or stable disease and then went straight into transplant, it appears that group is doing better. In comparison to group where transplant was done when patients start developing some issues such as transfusion dependence or increasing blasts in the blood. And the group E is the group of patients where they transformed to have leukemic transformation. And the results of group E is probably worse than this, because this group only, in this study, we have only taken patients who were able to get to transplant in this group, and these patients received some kind of either FLAG-IDA kind of induction therapy or hypomethylating agent. And there's a possible that some of these patients who transform into acute myeloid leukemia, they never reach the transplant stage, and we have not collected that data in this study because of the retrospective nature of this study. So this study does give some idea. No, the other thing which this study does not take into account, the group which waited, so there is a lag period. So, when you start somebody on JAK inhibitor therapy, there could be a 2-3 years of, patient can have a good quality of life, and that is not taken into account group B, C, and D. So what do we do in our program? We try to give a patient very balanced view of both pros and cons of JAK inhibitor therapy and the transplant, and then let patients sort of, make that decision whether they want to go with it. I always tell my patient that they should see an expert before making the decision whether they want to go for transplant or not. So what are the other major issues related to transplant? So the three major, I can categorize them into three main categories: regimen-related toxicities, graft failure, and graft versus host disease. Patients with myelofibrosis tend to have a high risk of hepatic toxicity. So this was a very simple study done by one of our medical students. And what we looked at, myelofibrosis patient who had gone through transplant, what was their sort of, in first 6 weeks, what was their hepatotoxicity? And then we compared with a control group of myelodysplastic syndrome patient who had gone through transplant, and it was a matched control. Again, we saw that there was a very high risk of grade 2 or 3 hepatotoxicity in these patients, which was almost double than the patient with MDS. So we hypothesized from there that maybe something we are missing in these patients, we are not characterizing them well. And one of the missing factor which we thought could be, presence of portal hypertension, asymptomatic portal hypertension in this group of patients. So then we implemented a strategy to screen our transplant candidates for evidence of portal hypertension with an upper GI endoscopy and Doppler ultrasound. And to our surprise, we have now screened almost about 32 patients since we put that screening strategy in place. We started picking up about in 25% of the patient asymptomatic, moderate to severe portal hypertension. So that can again go into your decision making. So if you have a patient with moderate to severe portal hypertension, should that patient have transplant, or should you do further investigations to characterize their liver, whether there's any other additional factor which you can optimize prior to for that patient to go for transplant. Graft failure, a major problem with the transplant. And these are the only two prospective studies which have been done in the field of myelofibrosis. The first study was done by EBMT group. They described that the primary graft failure was only 2%. However, they also described that the 11% of their patient had needed some kind of stem cell boost because of the graft dysfunction. In the MPD consortium, a study which was published last year, led by Dr. Rondelli, and there was a high risk of graft failure to the extent of 24% described in unrelated donor arm. So this appears to be, this is a major problem in patients with myelofibrosis. So one of the problem is that you can fix a problem if you understand the problem. The biology of graft failure in myelofibrosis is very poorly understood. Could be potential causes, could be, obviously severe marrow fibrosis, which has poor marrow environment for the donor stem cells. These patients have significant splenomegaly. Sometimes engraftment can take place in spleen. Some of these patients are heavily transfusion dependent, can produce alloantibodies, which could be a potential risk factor for graft failure. There is some suggestion from some experimental studies that TNF-alpha is a negative regulator of expansion and renewal of normal hematopoietic stem cells and facilitates expansion of JAK2 cells. And we know that patients with myelofibrosis have all these high cytokine levels. Could high cytokine levels be contributing towards graft failure? And then a point which was discussed earlier today, the interaction between the stem cell and the marrow niche. Again, this is a very important area. So the problem is that we at present don't understand in an individual patient graft failure is happening, why it is happening, and that is a major problem in this area. Graft versus host disease, from the studies which have been done in this area, if you just look at the incidence of graft versus host disease grade 3 and 4 and compare it to patients such as MDS or acute myeloid leukemia, the incidence of graft versus host disease in myelofibrosis does appear higher. Could this be related to high cytokine levels, which are quite prevalent in patients with myelofibrosis? So can we do anything to overcome these barriers? Again, unless we understand these things at a deeper level, at a biological level, I think it will be very difficult. So a few years back, when ruxolitinib phase 1, phase 2 studies were completed, and several investigators thought of using ruxolitinib prior to the transplant, and the rationale is ruxolitinib is effective in decreasing the spleen size, decreasing the cytokine levels, and these may translate into a reduced risk of graft versus host disease. Ruxolitinib can also improve overall well-being and performance status. Again, performance status has a major impact on outcome of transplantation. So can all these factors result in better outcome after the transplantation? So since then, a very controversial literature has emerged in this area. So this is a study which was presented by a French group at ASH a couple of years back, and they described some very unusual side effect which was seen in this patient population, such as tumor lysis syndrome, cardiogenic shock, etc. in this study. And it was very difficult to try to figure out why this side effect was happening. On the other hand, there are several groups, including ours, described in small retrospective studies the beneficial effect of using JAK inhibitor prior to the transplant. And in the most recent study, which I already mentioned, this is that we collected data on about 100 patients. And in this study, 66 patients who went on to receive directly after receiving JAK inhibitor went on to transplant. We tried to see what was the issues and what was the problem. We identified there were 2 patients who had significant symptoms after stopping ruxolitinib and going on to the transplant. And if you focus on, in both these patients, the interval between stopping the JAK inhibitor and the start of conditioning therapy was more than 7 days. And in both patients, transplant was rescheduled, and these patients had significant symptoms resulting in hospital admission at the time of stoppage of ruxolitinib therapy. Now, we already have this information from the COMFORT-1 trial that once you stop ruxolitinib, the myelofibrosis symptom tend to return back, and usually the time to return to myelofibrosis symptom is approximately 4 to 5 days. So one of the things which we always suggest or advise is that if you use ruxolitinib prior to the transplant, try to continue ruxolitinib right up to start of conditioning therapy, or gradually taper ruxolitinib over a 4 to 5 days prior to the start of the conditioning therapy. And this concept is being studied as a part of prospective trial with the MPD consortium, where we give ruxolitinib for a couple of months prior to start of the conditioning therapy, and this is an ongoing trial. So I conclude with these take-home messages. Stem cell transplant is an appropriate treatment for selective patients with myelofibrosis, which are usually intermediate to high-risk disease, and some selected patients with intermediate one-risk disease. The selection of patients should be individualized based on patient wishes and other careful review of patient disease and transplant-related factor. And when using combination of JAK inhibitor therapy and transplant, JAK inhibitor should be slowly tapered off and stopped near to the start of conditioning therapy. Thank you.